Hello, welcome again to another edition of Matters of the Heart, brought to you by Haverhill Community Television and Pawtucket Medical Associates. I'm Seth Bilazarian, a cardiologist with PMA, and I'm with my associate, Dr. Min-Soo Sung, a gastroenterologist in our group, a specialist in disorders of the esophagus, stomach, and intestinal tract, as well as the liver. And he's going to talk with us today about a topic which is interesting to me as a cardiologist because it's an important problem for me as a cardiologist because the problem he's going to talk about is called gastroesophageal reflux. It goes by the short name of GERD, G-E-R-D. It can show up as heartburn, but the reason why it's important to me as a cardiologist is it can cause chest pain. It can be confusing for our patients whether their issue is heart-related or the esophagus. So Dr. Song is going to talk to us today about GERD, about what causes it, how it's treated, and to teach us some things about it. So thanks for joining me today.
Oh, thank you for inviting me. So the GERD is a very common problem, and I see a lot of patients who complain to me about multiple symptoms, but GERD I find is very common. And in the US, it is a very common problem that as an outpatient, for gastroenterologists, it is #1 problem. In 2004, studies have shown that most #1 visit was due to GERD. And in hospitalization, the 10th most common diagnosis was the GERD. Therefore, it is a very common problem. And I think that the incidence or the number of people complaining of GERD is increasing. Now, it is a very common problem in the US, and there are many reasons for GERD, and I will get to why. But it is also a common problem in Europe and other countries, but much less so. In the US, up to 40 to 50% of people complain of GERD or reflux or heartburn at one time or another. And if you compare to other countries, in Europe, for example, depending on the European countries, the incidence is much less. In Italy, for example, it's about 20%, while in Swiss, it's about 7%. In Asia, it is much less common. The risk varies from countries to countries. However, studies have shown that the incidence is about 0.5 to 7%. Now, you may wonder, why is it more common in the US?
I'm wondering, tell me, why is it more common in the US compared to both Asia and Europe?
And I think it is because of our diet. North American diet has a lot of things it does. We talk about how we should increase fiber in the diet and we should have healthy diet. But North American diet in general is very poor because of the fast food, greasy, easy food that we can eat. And also the other cause is being overweight or obesity. The studies also have shown that when you're overweight, the complaint of GERD does go up. And also studies have shown that the prevalence or incidence of the GERD is associated to actually the stratum of the BMI, meaning that the higher the BMI you have, the higher the chance you will have reflux.
So the BMI, you mean, is the body mass index. That's a measure of how fat someone is or obese.
Right.
So the higher someone is overweight, the more overweight they are, the more likely they are to have GERD.
Yes.
Okay.
And it's BMI is a body mass index, which is the ratio between your height and weight. It's a simple calculation. You can go to a website and then look up, and then you can put in your height in inches and then your weight, and it'll give you the body mass index. Healthy body mass index, we think, is between 19 and 25. It is slightly less for Asians, but for white Caucasians, it is between 19 and 25. For a person whose body mass index is between 25 and 30, is overweight. Above 30, we consider them as obese. And people who are obese have a very high risk of getting this reflux and heartburn.
Very good. Let me just ask a general question. As you were speaking, I was saying, a person in our audience might be saying, well, these doctors are talking about heartburn. Mm-hmm. So what? Someone has heartburn, you can drink some water or take some antacid. What's the real concern from a gastroenterology standpoint about heartburn or reflux? What are the consequences of this?
So, I think that in the 70s, if you look in the past, if you watch old TV, if someone complained of heartburn, then they used to tell them, just take some water or take Tums or antacid and it'll get better. However, we have realized that with more people complaining of heartburn, there has been more complications, such as people who have chronic reflux can have esophagitis, which is inflammation of the esophagus. Now, the degree of inflammation in the esophagitis does not correspond to the actual symptoms, meaning that people who complain of heartburn or reflux all the time, as I mentioned before, about half the US population complains of heartburn one time or another. However, when you actually do the endoscopy, we only find esophagitis in about 7% of people. Now, if you have chronic inflammation, it can cause complications such as it can cause bleeding, it can cause ulceration in the esophagus, and all these can lead to damages. Now, damages meaning it can cause stricture, which can cause narrowing of the esophagus, and people have difficulty swallowing, in which case you have to go and do procedures to relieve that. And sometimes people develop what's called a Barrett's esophagus or change in the cell lining. Now, we talk about esophageal cancer, and there are different types of esophageal cancer, and reflux increases one type of esophageal cancer. And that's why we are very concerned at this time, and we don't ignore it anymore.
Okay, so let me just summarize what I think you said. So heartburn could be just benign and just be fine, but it might be something more as a sign that the acid is irritating the esophagus, causing, I think you said, a stricture, which is like a narrowing of the esophagus, or an inflammation that can actually damage the lining of the esophagus that could ultimately lead to cancer. Doesn't necessarily, we don't want to scare people, but it's a concern.
Right.
Is that a good summary of that?
Yes, it is. And it's because I don't want to scare people, and then, I don't want people to tell the primary doctors to send them to have the test done or talk about cancer. However, it is people. If you have heartburn once in a while, and that's why there are medications available over the counter. And if you take medication for a couple of weeks, and if it gets better, that's fine. But we do worry about people who have chronic heartburns, for people who require medications for months or years, or people who have chronic reflux. Now, it does get more interesting, or it does get more difficult, because we talk about heartburn and reflux. However, there are other symptoms we also talk about. We just ask people about difficulty swallowing. And we also mentioned about, you mentioned in the beginning that you worry about chest pains and so on. So chest pain is also one of the signs that you could have severe reflux. Now, of course, it doesn't, as I said, the severity does not reflect the actual disease or the damage. And whenever someone...
When you say that, I want to make sure that I understand, but also for our audience. So you said the severity of the symptoms is not a reliable about how bad things could be inside.
Right.
So just to make sure I understand, you could have really severe symptoms and have very little problems, or you could have a little symptoms and have a really bad problem. Is that what you mean?
Yes.
Okay.
People, I have some patients complain to me, they just have slight discomfort, and when you do the endoscopy, one of the diagnostic tests, we find severe inflammation or with Barrett's esophagus. While someone complains to me they have complaint of reflux and heartburns every day for many years, we look inside and everything looks okay. So the severity of the degree or the severity of the symptoms does not correlate to the actual degree of damage. And of course, you mentioned before that whenever someone has these kind of symptoms, you also, if you're young, it's not of a major concern, but as you get older, we do have to make sure that you don't have any cardiac disease.
Okay, great. So one of the things that often seems like patients will say to me in their history is that they've been told by a doctor that they have this problem called a hiatus hernia, they sometimes say, or a hiatal hernia. Tell us about how that plays into this, what that's about, and make some sense of that for our audience.
So between the stomach and the esophagus, well, let me take a step back. The reflux happens when stomach content or stomach acid comes up against into the esophagus and causes irritation of the esophagus.
So we have an esophagus, which is the food pipe,
Right.
and then below the diaphragm is our stomach.
Yes.
And the stomach has a lot of acid to digest our food.
Right.
And the acid is supposed to stay there and not go back into the esophagus.
That's right.
So you're saying that this reflux is when that acid goes from the stomach back into the esophagus.
Yes.
Okay.
And the stomach makes acid to digest food, but it also produces buffer to protect it from digesting itself. That's why we have produced acid. However, when there is no mechanical valve, but there is no door to prevent acid from coming up to the esophagus. There are different mechanisms to prevent this, such as that there is a small muscle, circular muscle, that kind of impinges on the esophagus at the lower part, which causes the tightening of the esophagus, which is normal, physiological tightening. There's the diaphragm muscle, which kind of impinges on the esophagus. And there's the fact that there's a different pressure gradient between the chest and the abdomen. And there's when esophagus goes into the stomach, to the abdomen, it makes a little angle. So there are different mechanisms to prevent reflux, but there's no actual valve or door.
So you mentioned 4 different ways that the grand design is to keep the acid into the stomach.
Right.
But despite those 4 ways, some people still get the acid to come back into their esophagus.
Right, and it's not perfect. That's why we get reflux and we get heartburn and all these complications. And one of the mechanisms that disrupts this, one of the things that disrupts this mechanism is hiatal hernia. So hiatal hernia hernia. Hernia just means that when an organ or something is in a space where it's not supposed to be. So hiatal hernia is when the stomach, which is supposed to be below the diaphragm in the abdominal cavity, comes up to the chest. And there are different types of hernias, and a simple hiatal hernia can't cause reflux because the circular muscles that's supposed to be part in the chest and the abdomen is completely in the chest. The angle that goes in, the angle of his or the angle that the esophagus makes when it goes to the abdomen is all completely in the chest. The angle is no longer there. The diaphragm that pushes on the lower esophageal sphincter or the junction is not there anymore because the part of the stomach has come up. So therefore, the acid has chance to go up. So they're all hiatal hernia does increase the risk of the reflux.
So just to be clear, though, the hiatal hernia, I think, is where the sum of the stomach is actually up in our chest.
That's correct.
So that is something that can be seen on some kinds of different imaging studies, like a chest x-ray sometimes can show that. So there's different kinds of studies. So if a patient has that, they may or may not have heartburn, but you're saying if they do have it, there's more likely that they will have both heartburn and gastroesophageal reflux or GERD.
Right.
Is that right?
Yes.
Okay, great. So help me understand. We launched right into this and started talking about heartburn, and you mentioned during the discussion earlier that sometimes people have difficulty swallowing. What are the different symptoms that people should be concerned about or think about that might be related to this GERD problem?
Well, I mean, GERD is just, just gastroesophageal reflux disease. So most common symptoms are heartburns, which gets just burning sensations in the chest, mostly in the mid-chest, or the reflux, where people actually sense the acid coming up against their esophagus, and usually people complain of sour taste or bitter taste in the back of their throat.
It's almost like they're going to throw up. They feel
That's
like
right.
a nausea, or maybe they just have the burning in the back of their throat.
Right, and it is, there is another disease called rumination, where people actually tend to kind of throw or vomit things up or push things up at themselves with the force, and then kind of have, kind of regurgitate their food. But this reflux doesn't happen. It's not a voluntary thing. It happens involuntarily.
Okay.
Other symptoms involve, the difficulty swallowing happens when you have either the narrowing from the cancer or ring from the hernia, which is one of the anatomical variation. And the other thing, if you have severe inflammation, it can cause difficulty swallowing.
So of those things, I guess, which one of those things you mentioned should raise the concern for a patient enough to talk with their primary care doctor or seek a consultation with a gastroenterologist? If someone's getting it all the way up in the throat, if they have that burning or sour or bile type taste in the back of their mouth, is that bad enough? Does that cross over to being worrisome enough that evaluation is warranted? And how about the swallowing difficulty? You feel like food gets stuck. Are those two things that really we've moved more from this is probably heartburn, we can keep an eye on it, to really wanting to evaluate it?
Right. So as I said, the degree of the symptoms or the severity of symptoms does not correlate to the actual damages or what's going on inside. Therefore, I think the most, I would get worried when you have heartburn for many years or start having or first of all, if you start having heartburns new. If you never had any heartburns before, if you start having some heartburns, I talk to your primary care doctors and discuss with them. You may need some treatment or management, but I mentioned it to primary care doctor. Or if you had it for a long time and if you ignored it for many years, that's something that you should talk to your primary care doctor, because the longer you have, the higher the chance you could have a damage. Difficulty swallowing is another thing. If you start having difficulty swallowing, then that's something that you should mention to your primary
And when you
care
say difficult
doctor.
swallowing, feeling like maybe food is actually getting stuck in your chest, so when you swallow, it doesn't go all the way down. It sort
That's
of,
right.
Or you have to actually slow down your eating because you notice pieces of food don't go down as easily.
Yes.
Those are what you mean when you say difficulty
yes.
swallowing.
Mm-hmm.
Okay.
And there are other symptoms I didn't mention, which is that chest pain is one of them. So if you have chest pain with reflux, definitely you should go see your primary care doctor, because first of all, we have to rule out, make sure there's no cardiac disease, and then there's no esophageal damages. The other is the asthma. I mean, some people think that the asthma is associated with reflux or the shortness of breath, because when you have reflux, some of the acid can go into your lungs and cause this small aspiration, causing lung damages.
Okay. So you mentioned a whole bunch of symptoms that people should think about, and hopefully people will be taking notes and talking to their primary care doctor about it. Let's move to what happens if the primary care doctor does think this warrants evaluation, tell us some of the tests that patients might have to go through to get this straightened out.
Okay. The first thing is that if it's something new, and if you never tried any medications, if you need over-the-counter medications or like such as Tums or Maalox or Mylanta, we do recommend some other over-the-counter stronger medications like Zantac or Pepcid or Prilosec, which are available over the counter, and just try them for a couple of weeks, and then your primary care doctor will also recommend that as well. And if it goes away, we recommend you to stop. If you look at the label on these medications, it says to try for a couple of weeks, and if it doesn't work, then go see your doctor. And the reason is because we worry about something going on inside, or you may need a longer treatment, in which case we have to think about complications or the side effects of the medications. Second thing is the doctor may send, if there are different test evaluations we can do. Now, the evaluations are for different reasons. One is to check actually, is there a real true acid reflux or true reflux? And to do that, there are invasive and non-invasive testings. X-ray is one of them, where something called barium swallow, where you swallow. It's done by the radiologist at the hospital, where you drink some barium, and then they'll take pictures of the chest as the barium goes down. That test, if you have reflux during the time of the test, you can actually see the barium coming up against in the esophagus.
So let me just tell patients so they know what you're describing, just of what a barium swallow is. So a barium is basically this white chalky material that looks white on an X-ray. Right. So when we swallow it, the white all goes down to our stomach. And if the white comes back out of the stomach, we know it's going the wrong way. So that's a sign of reflux.
Yes. Now, the radiologist can also, if there's any severe inflammation or severe abnormalities, then the radiologist can also look at the esophagus and see if there's some abnormalities. Now, the gold standard examination to evaluate the esophagus is EGD, or esophageal gastroduodenoscopy, or endoscopy, which just means looking inside the stomach or upper part of the GI tract. And that's where we come in, where as a gastroenterologist, to evaluate the esophagus to see if there's any damages or any cancers or something that we have to be concerned about.
Okay. So just to review what I think you said is, most patients with these symptoms would get a 2-week trial of a medicine, used examples of like Zantac, Pepcid, or Prilosec. And if they do great and the symptoms go away, usually nothing else would be recommended. But if they have persistent problems or they need a longer course, usually they would be moving towards one of these studies.
Yes.
And the 2 studies you just helped us understand was the barium swallow and the endoscopy.
Yes.
Now, I'm older than you, so I know that many years ago, almost everybody first had barium swallow, and now it seems like that's less frequently the first test, and more often endoscopy is ordered. And I don't actually know the answer, so tell me. But I guess what I'm wondering is, if I were to be recommended for a barium swallow, if there was an abnormality, would I get an endoscopy anyways? So does it make sense to just go to endoscopy? Help me understand that.
And usually that's what happens. I mean, endoscopy is the gold standard to evaluate the esophagus, because we can actually see what's going on inside, rather than depending on because X-ray is a great test, but it is still we are indirectly looking at the inside. While endoscopy, we're actually visualizing the lumen of the esophagus, and we can also check if there's any damage, any inflammation. Also, if everything looks normal, we can still take some biopsies, small tissue samples, to look on the microscopy to see if there's any microscopic damages.
Right. So just to make sure everyone knows, again, we want to make sure it's clear. We talked about the barium swallow, which is just drinking something and taking an X-ray. The endoscopy is a situation where a patient is given some light sedating medicines, either in a hospital or in our office in an endoscopy center, for instance, and they would be gently put to sleep. And then you or one of your colleagues that does this, specializes in this, would actually put a hose that has a camera on it, and you could watch on the TV every bit of the esophagus to see if there's any redness, inflammation, or other kinds of problems, or ulcers. You could examine the whole thing from the top of the throat all the way down, including the stomach.
Yes.
So that's what an endoscopy is, and that's, as you said, a gold standard, the best way to evaluate this.
That's correct.
Okay.
Now, as I said, the degree of the symptoms does not correlate to what we actually see inside, or the degree of what we find. And therefore, there are other. Sometimes when I tell patients that everything looks normal, they think that I'm kind of denying their symptoms.
That's
However,
funny. They say it to me when I do a heart test, and I say, And I start with that. I say, I believe you're having these pains, but it's not from your heart. That's what I say.
Right.
And you say the same thing.
And the patient, I mean, they have to understand that I do believe that they have symptoms,
Right.
and it's just that it's the symptoms is not severe enough to cause damage.
Which is good.
Which is good. And there is actually, we have a term for that. It's called NERD, which is N-E-R-D, or non-erosive reflux disease, which is just that people have symptoms of heartburn or reflux without any erosions or any damages.
Okay.
Now those are, again, the treatment is similar. Treatment is to try the acid suppression such as Zantac or Pepcid, which are one class of family, and the other class of family, the other medication is Prilosec, which is a proton pump inhibitor. Those are newer ones, relatively newer compared to the other ones. And there are other medications such as Protonics, Nexium, Acifex. They're all one class of family. And the treatment is to try these medications.
So you mentioned two tests, the barium swallow and the endoscopy, or EGD. Are there other tests that sometimes are used to try to figure out what's going on with the esophagus?
Yes. Now, the barium swallow will closely look at the esophagus, and barium endoscopy with EGD will look at the damages or the mucosa of the esophagus. Now, the question is, does the person, when patient complains of reflux, is it truly due to reflux? And there are other tests we can do. Now, when someone comes to see me for reflux, I usually try to maximize the medication first, because if it is truly acid reflux, then trying the maximum of the medication should make it better. However, some people say it doesn't get better even with the maximal dose of medication, in which case I sometimes go on to pH study, where pH study can be done also by the ear, nose, and throat specialist, where we actually measure the pH, which is the acidity of the esophagus, where when you have, so basically what we do is with endoscopy, we place a little device in the esophagus, which will fall off on its own. People don't have to worry about it afterward. However, it does record the acidity of the esophagus for over 48 hours. And we also ask people to keep a little diary where mark down when they get symptoms, and we correlate their symptoms to the actual acidity. And that way we can check whether the medication is truly working or not. That way that differentiates between the acid reflux and non-acid reflux, because the stomach makes acid, but it also makes other chemicals, and there are also other chemicals such as bile that's made by the liver, which can also come up, and they can also cause these sensations or these symptoms. The other test, which is relatively new, is called impedance testing. And that's not done here locally, but it is done at tertiary care centers like Leahy or Mass General. And that is to test whether you're actually having reflux of other chemicals as well as acid.
Okay. So earlier you talked to us about one of the hazards or complications of reflux is that the lining of the esophagus can change from a normal healthy lining to an abnormal lining that can be a risk for cancer. And you told us that was called Barrett's esophagus. Yes. So the name Barrett, I guess, is named after the person who described it, I'm guessing. Who's at risk for this problem, Barrett's esophagus? Who should worry about this? And tell us a little bit more about that.
Okay. The Barrett's esophagus is much more common in the U.S. I mean, and we do worry about it because we think that we know that it does lead to cancer. Fortunately, the risk of cancer that we thought it caused is not as high as anymore. It's not as high as we thought. Meaning that we thought that up to 1% of people with Barrett's esophagus develop cancer, but we are now realizing that it's actually less than that, which is we're happy with. As I mentioned, in the U.S., the reflux is higher, and that's probably because of the obesity. I mean, North American diet has a major role as well. So, I mean, as I mentioned, there are different mechanisms that prevent reflux, and there are food that also causes the disruption of those mechanisms. For example, people who drink a lot of caffeine or coffee, tea, chocolate.
So you're now helping us understand for our patients in the audience what things can make reflux worse.
Right.
So you mentioned, I'm sorry, caffeine and chocolate.
Caffeine and chocolate, which can increase reflux. And these food or some drugs can relax the circular muscle, and they can increase the reflux. I mean, by preventing reflux, it'll also, if the risk factors for the reflux is also a risk factor for Barrett's.
So if we quiet the amount of acid coming back into the esophagus, we'll have less symptoms and less risk of the cells turning to Barrett's esophagus.
Right. And I'm sorry, I think I jumped the gun. But however, the risk of the incidence of bladder in the U.S. is increasing. As I mentioned before, that there are different types of esophageal cancer, two major ones. One is the squamous cell carcinoma, squamous cell cancer, which is very common with smoking. Incidence of smoking has gone down, smoking and alcohol. However, the incidence of Barrett's esophagus is going up.
Okay.
And we think that's because of the reflux, even though the incidence of smoking is going down in the U.S.
Okay. So one thing we often talk about on this show is preventative strategies. Dr. Sunny Srivastava, who usually does the show with me, is very fond about talking about strategies that are not medical, dietary, lifestyle changes. We don't have much time left. Can you share with our audience, besides the caffeine and the chocolate, general lifestyle, non-medical things people can do to reduce the reflux problem?
I think the number one thing is to lose weight. I mean, people with the high BMI especially need to lose weight. Second is to avoid these offending foods, so caffeine, anything that contains caffeine. Cooked tomatoes is another. When the fresh tomatoes are okay, but when you cook the tomatoes, it also produces chemicals that can increase reflux. And mint. Mint is interesting because people chew mint gums to help the heartburn, but mint also increases reflux, so it kind of neutralizes what you're producing. And people talk about spicy food as well. People talk about that they get heartburn with spicy food, but it's also spicy food is bad because it also causes burning as it goes down because it's the capsaicin, the chemical in the spice.
Okay.
But the measure is weight loss. I mean, people should definitely lose weight.
Okay. We know that how much a struggle that is for patients, but I think that that's another example of a health benefit of good lifestyle changes with weight reduction will reduce this problem as well.
Yes.
Well, what a fantastic review of the subject of gastroesophageal reflux disease, or GERD, G-E-R-D, which often manifests as a symptom called heartburn that people know about as sort of sour tasting or sour feeling or discomfort in their lower chest or sometimes into their chest. My associate, Dr. Min-Soo Song, has done a beautiful job reviewing the issues related to why this is happening, it's increasing in the United States, and some strategies for both treatment and prevention. And hopefully our audience has benefited by that, and we thank you for joining us again for another edition of Matters of the Heart. Hope to see you next time for another episode. I'm Seth Bilazarian. Thanks.